continuing our session on Taming the Flames, as Alberto initiated. We are going to talk in a few minutes about the cardiorrenal-metabolic risk constellation. These are my disclosures, and we are going to start with obesity. I guess we all know obesity is not only a static condition anymore. Obesity is not even only a risk factor. Obesity has been considered a chronic, progressive, and relapsing disease by several entities. And another big problem is obesity has increased for decades in several regions of the globe, as we can appreciate in this study and in several others. We see here that in all large regions of the globe, there has been an increase in obesity. And another big problem is there is a projection that obesity is going to continue increasing also in all parts of the globe. And unfortunately, obesity is related to several complications in all systems in our organism. We can see in this very interesting study that was based in two cohorts, the Finnish cohort on the left and the UK Biobank cohort on the right, the association between obesity and another disease. In the first graph, on the top graphs, a second disease. In the middle one, a third disease. And in the last one, on the bottom, a fourth disease. So these are the associations between obesity and another disease, second, third, or fourth. So we can see a big difference between individuals with obesity and the ones with healthy weight. And what are these diseases? What are these morbid conditions associated with obesity? We know several of them. We can see that these diseases are in multiple systems. Of course, diabetes, among the endocrine associations, also several cardiovascular diseases, hypertension, ischemic diseases, also heart failure, but also gout, or osteoarthritis, and several others. So we can see that the ones that are more highlighted in a stronger color are the ones with the stronger associations. Certainly, diabetes is one of the diseases that are mostly associated with obesity. We see here in this very interesting graph and very worrying one, the difference on the trajectory of type 1 diabetes in the bottom of the graph, very flat in the last decades, and it's going to continue being flat in the future, while type 2 diabetes has increased, and it's going to continue increasing, especially in some areas of the globe. We can see written here on the right, the regions that are going to have a percentage of type 2 diabetes greater than 10%, North Africa, Middle East, Latin America, and Caribbean. And this increase has been mostly due to high BMI. So there is a very close association between high BMI and type 2 diabetes, as we all know. This is also another very interesting study that shows how transitions of cardiometabolic and renal phenotypes have happened. And this is a study particularly done in US. So most of the risk factors that we've been treating, hypertension, dyslipidemia, diabetes, etc., these are all very important. But the relevance of these risk factors have changed in the last years. So we can see here in the purple color how high cholesterol has decreased in terms of a percentage of population with that. So high cholesterol is still, of course, very important, a very a high percentage of individuals have that, but there has been a decrease probably due to control. Also, in terms of high blood pressure here in blue. On the other hand, we see here severe obesity. The phenotype of severe obesity has increased in US dramatically, together with here in blue, light blue, low EGFR, so low glomerular filtration rate, so more individuals with the phenotype of chronic disease, chronic kidney disease. So because of the importance of obesity and also the expansion of obesity everywhere and all the connections that obesity has with cardiovascular diseases and also chronic kidney disease, the two of them very important causes of death, American Heart Association published a statement, a scientific statement, reuniting the evidence for the science and management of this syndrome called cardiovascular kidney metabolic syndrome. So why to put them all together? Because they are all very related. There are biologic connections that really link all these conditions together, and fortunately the treatments, the management has been very similar with benefits in all these conditions. So we are going to talk in the next slides a little bit about these connections, about dysfunctional adipose tissue and cardiovascular diseases. We know they are linked because of secondary risk factors that come with obesity, so hypertension, dyslipidemia, diabetes, but also due to intrinsic alterations because of obesity, inflammation, oxidative stress, vascular dysfunction, but also about the link between adipose tissue and chronic kidney disease. This interaction has been less explored in the last years, but has been highlighted more recently. So first, about obesity and cardiovascular diseases. We, for a while, focused on atherosclerotic disease. We know this is a very important cardiovascular condition, maybe the most prevalent one, but there are other cardiovascular conditions that are equally important and that have everything to do with obesity. Heart failure, especially preserved ejection fraction heart failure, also arrhythmia, atrial fibrillation, thromboembolism. This is a study among several others that highlight the association between BMI and also other anthropometric measures that are related to obesity, like waist circumference and waist to hip ratio, and atherosclerotic diseases. So we see on the top the relationship among these measures, BMI, waist circumference, and waist to hip ratio, and also coronary heart disease. We see that even after adjustment to other risk factors, there is still a correlation, a positive correlation between these measures and coronary heart disease, especially when we talk about these measures of central obesity, waist circumference, and waist to hip ratio. And this is the same observed with ischemic stroke. Few years ago, we started observing also the relationship between obesity and the risk of heart failure. We see this publication of 2002 already correlating individuals with overweight or obesity and also the incidence of heart failure. We see there is like a dose response, right? Individuals with overweight regarding to normal individuals regarding weight had a higher incidence of heart failure. Individuals with obesity, even a higher incidence of heart failure. But now we have more detail on that regarding the type of heart failure that is more related to obesity. We see very clearly here that although both kinds of heart failure, reduced ejection fraction and also preserved, have a relationship with obesity, the heart failure with preserved ejection fraction have a steeper relationship with BMI. We see that individuals have a higher risk of HFpEF with with a higher body mass index than individuals with reduced ejection fraction. We cannot forget about arrhythmias. There is also a higher incidence of arrhythmias in individuals with overweight and obesity, especially atrial fibrillation. And this is a list of several studies showing exactly this association between BMI and atrial fibrillation. And I brought here a specific study showing more clearly this association between BMI and the risk of atrial fibrillation in both men and women. The higher the BMI, the higher the risk of atrial fibrillation. And what are the connections between BMI, high adiposity, and cardiovascular diseases? I think this graph summarizes all the biological connections between adiposity and both atherosclerotic diseases and also heart failure. We have here on the left the interaction through inflammation. So adiposity increases inflammation. There is increased inflammation in the adipose tissue, initiating with hypoxia, so secretion of inflammatory mediators. This inflammation, both in the organ and also systemic, impairs insulin signaling, induces insulin resistance. So that's why there is inflammation actually driving prediabetes and diabetes, which is a factor, of course, implicated in cardiovascular diseases. There is also another connection through lipid production, increased adiposity, increases lipid production, hydrolysis of triglycerides. There is infiltration of free fatty acids in the liver. This is also a cause of liver disease. And the atherogenic dyslipidemia that we all know is also implicated in cardiovascular diseases. And also there is increased activity of the sympathetic nervous system contributing to hypertension, also increased activity of the renin-angiotensin-aldosterone system, also inducing hypertension. And there is also mechanical stress, of course, contributing also to these diseases, cardiovascular diseases, and also other conditions like obstructive sleep apnea, osteoarthritis, and etc. Now, I'm going to focus a little bit on the interaction between obesity and renal kidney disease. I brought this data that I found very interesting and actually scary, how chronic kidney disease has increased a lot lately together with obesity. So it is a major global health issue. Its prevalence is rising and it's increasing in importance as a cause of death and risk factor for cardiovascular death. And this graph shows all the risk factors that are related to this increase in chronic kidney disease everywhere in the globe. And you can see that the three most important bars are the red, high fasting plasma glucose. The second one is high body mass index as a very important attributable risk factor to the increase in chronic kidney disease, and also high systolic blood pressure. So this is data showing the epidemiologic connection between obesity and chronic kidney disease. But what are the mechanisms through which obesity leads to kidney damage? We have summarized some that connect obesity with cardiovascular diseases, and there are some that are very similar and that drives also kidney damage. For example, obesity-related disease states like diabetes, hypertension. We know these two diseases are very important risk factors for chronic kidney disease, but are also other biological connections like hemodynamic effects, intraglomerular hypertension. This happens with obesity, podocyte injury, obesity-related glomerulopathy, vascular shear stress. Regarding neuroendocrine effects, hyperinsulinemia and insulin resistance also drives lesion of the glomerulus. upregulated renin-aldosterone axis, also greater sympathetic tone. This is also inducing kidney disease. Ectopic lipid accumulation drives inflammation, oxidative stress. This is also drives kidney injury. And lastly, but very important too, fat compression of kidney and renal ileum. So especially in individuals with very important obesity, there is a compression of the kidney, and this is also inducing lesion. So finally, with all these connections, the AHA advisory, the AHA statement on cardiovascular kidney metabolic health divided this continuum in stages. So there are stage 0, stage 1, stage 2, stage 3, and stage 4. Of course, this is a continuum, and we need to intervene very early. So the earlier, the better. But of course, if we didn't intervene before, let's try to intervene even if the individual has already some kind of disease. So what are these stages? In stage 0, this is primordial prevention. This is where everybody should be. In this stage where the individual has no risk factor, let's focus on keep the individuals with no risk factors, trying to stimulate life's essential 8. In stage 1, this is where everything starts. There is excess or dysfunctional adipose tissue. It's very important not to measure only BMI, but also another anthropometric measure like waist circumference or another ratio, for example, trying to identify individuals that have already excess of adipose tissue. In stage 2, the individual has already some sort of risk factor or CKD. So there is already hypertension or dyslipidemia, especially hypertriglyceridemia, metabolic syndrome, and or type 2 diabetes. And the individual can have already moderate to high risk CKD. But this is only going to be detected if measured. So this is also some very important tip that this document is giving us. Measure whenever you can these risk factors, especially in individuals with a risk for these factors. In stage 3, the individual has already some sort of subclinical CVD and CKM. So subclinical atherosclerotic cardiovascular disease, generally measured through coronary calcium, or subclinical heart failure. And this we can, of course, detect through echocardiogram or EKG or even some natriuretic peptides. And finally, stage 4, this is unfortunately when these diseases are being manifested already. The individual had already an infarction or has already clinical heart failure, atrial fibrillation, had a stroke, or a peripheral arterial disease. So just to finish, these document suggests, as I said before, screening approaches for CKM syndrome. So in adult individuals, individuals who have already a high BMI or a high waist circumference, measure it annually. In these individuals, also start focusing on the liver, on the kidney, measure urinary albumin creatinine ratio. So this is often not measured. So you can check on albuminuria. Sometimes the individual has a normal kidney function, but has already albuminuria. This is already kidney disease. Coronary artery calcium can detect already a subclinical atherosclerotic disease. This is also this should also be done in eligible individuals, and measure also an echocardiogram or cardiac biomarkers trying to detect subclinical heart failure. So these are tips that are detailed in the document. And finally, I'm not going to focus on that, but just to show to you that the document has already an algorithm for the management of patients with CKM. Lifestyle is basic, but there are several medications that are fortunately very useful for individuals with CKM. In all stages 1, 2, 3, and even 4. So I'm going to stay here. My summary is that there is a high prevalence of poor cardiovascular kidney metabolic health in the population. CKM health reflects the interrelationships among metabolic risk factors, mainly obesity, especially central obesity, CKD, and the cardiovascular system. Fortunately, there is a growing array of therapies and healthcare strategies that have great potential to improve outcomes for the patient with CKM syndrome.
Thank you, Viviane. Excellent presentation. I was thinking about the obesity and the cardio kidney metabolic syndrome. It's a really global health problem nowadays. Sometimes some doctor used to say the obesity epidemic. No, no, no. I think it's a really pandemic in my country or many, many countries around the globe. We have two-thirds of the population in obesity or overweight. Recently, the Global Burden of Diseases published a report showing that since 1990 to 2023, there is an increase in the morbid mortality rates. Historically, the curves went down, especially in the second part of the last century with the introduction of the angioplasty, the statins, and the cabbage. But nowadays, this curve, descending curve, is flattering since 2015 and now going up mainly for the exposition of the people to metabolic risk factors. This is a real problem in terms of global health. And also, you will be in accord with me, we have to incorporate liver disease among the cardio-renal liver metabolic syndrome, because all these kind of patients have muscle D or are going to have or in the way of having that. Tell me, Viviane, excellent presentation. I would like to move to inflammation in this cardio kidney metabolic syndrome and in obesity. Now there are very good information regarding the benefit of using ARGLP1 agonist in terms of reduction of overweight and reduction of cardiovascular events. But there is a constant reduction with this kind of drug of inflammatory biomarkers. I mean, C-reactive protein reduced more or less 35%, 37% in a select trial and others. What do you think about that?
Yeah, I think first on a short commentary on the first part of your discussion. I think it's really scary what's happening, right? We focused very much on hypertension and dyslipidemia, and these two risk factors have been still very important, and there is still a lack of control. But for a while we forgot about obesity, and the population got extremely obese in terms of frequency everywhere, and so we we may lose all the benefit we got in terms of reduced cardiovascular mortality, right, adjusted by age,
Correct.
that we got, right, due to the control of these risk factors, hypertension, dyslipidemia, and etc., smoking. So I think it's very important that we really discuss about obesity and its complications, and how what we can do to attenuate that. So I think it's very important, and definitely liver inflammation. I mean, this is a very systemic condition, right? And it drives inflammation. And I think when we thought about when we think about what to do with a high CRP, the first thing, right, Alberto, is to lose weight. If this is the case, to lose weight, I think is one of the first steps to cut CRP, right, to lower CRP. And of course, lifestyle is always the basics. So if we can do that through lifestyle, great. But unfortunately, we know that maintenance of lifestyle, right, forever, to keep to keep health, and to keep that weight controlled, and of course CRP low, it is very difficult, we know. So I think when indicated, the medications, the GLP-1 receptor agonists are extremely useful. Of course, I mean, they are not as accessible as they should, right? In my country, for example, in Brazil, we still have these medications at a high price, so not accessible to most individuals. And this document actually addresses all the social determinants of CKM, and indeed, I mean, social deprivation is a very important risk factor for obesity and all CKM, and of course, less access to these drugs. But I mean, the first thing that we need to discuss is that they are very potent drugs. They are very beneficial drugs, in terms of cardiovascular, liver, kidney, right? We have already a very strong evidence, right, Alberto, that these drugs are very beneficial systemically. So, I mean, once they are more accessible, it will be extremely useful to use them to attenuate the impact of CKM.
The important thing is that since the report, the presidential report that you mentioned from the AHA 2023, all the doctors have different uh, a different visions regarding the patient, because uh, now we have the integrated concept regarding the patient is the same. It's one
Uh-huh.
patient, not a heart, not a liver, not a kidney. But now, since we have drugs that are capable to act in different systems, also we have an integrated vision regarding the illness of our patient. And this is very, very, very important step forward in terms of the benefits for our patients. So, what do you think regarding the fact that many doctors do not integrate this kind of vision? And my concept, if we have to see the patient as just one patient with the multiple complication in the case of we are talking about. But many doctors are reluctant to have this kind of for example, the indication of try to manage this patient in integrated
Uh-huh.
cooperation between the nephrologist, the cardiologist, the endocrinologist as well. What do you think? How do you manage in your institution? This kind
I
of
agree.
patient is an unique patient you need
Uh-huh.
to manage.
No, I totally agree with you. I think there is a reluctancy in assume, right, the patient more globally. I mean, cardiologists, they have already a very long checklist, right, Alberto? We need to check on hypertension, of course, dyslipidemia, even diabetes, smoking, all the risk factors that are numerous. And of course, most patients come with already with a disease, right? Like an atherosclerotic disease or even heart failure. So the cardiologists need to manage all of that. But I think obesity is something that needs to be in this checklist, right? Obesity and some of its complications that were not part of the checklist of the cardiologist. But I think sometimes the cardiologist actually only send the patient to the nephrologist, for example, when the disease, the kidney disease, was already very advanced. So I think what the document and all the documents in this topic have suggested is that try to measure at least, try to measure urinary albumin ratio, creatinine ratio more often. Because if there is proteinuria, this patient already has a disease. So if you're not going to treat, so then send the patient to the right doctor. But at least if you measure, you're already doing something to this patient, right? Also, in terms of liver, if you detect hepatic steatosis, we're trying to insert in the consultation the calculation of the FIB4, right? Which is still not in the cardiologist consultation, but I think it's going to be part of it. I mean,
It's useful
that's why, yeah, that's why, I mean,
and
these
easy.
sessions are important. I know it's getting longer and longer, the list of the cardiologists and all the doctors, but I think we cannot just focus on cardio, especially because this cardio is connected to everything, right? And we need to detect the lesions very much earlier because there is something to do, right? And I
Viviane,
think that's it.
we have now very effective drugs, very safe drugs, but you mentioned you showed us the um, the cartoon showing the different stages of the cardiorenal metabolic syndrome. And the stage zero, you have to handle the eight essentials
I know.
because among the audience maybe may have a lot of young doctors. It's important to emphasize how you manage in your clinical practice these changes in the lifestyle, this kind of healthy lifestyle, but it's not easy in the real world. What do you think about?
Yeah, I think, I mean, I'm very happy that this Life Essential 8 are 8, right? I mean, it's been a lower number before. So we are trying really to stimulate health in all compartments, right? Sleep, of course, blood pressure, glucose, lipids, everything. I mean, the modern life is very difficult to handle, right, Alberto? I think we need more and more education, and of course, I mean, for the population, the government also needs to help with, safe parks, spaces for people to exercise, and with measures that uh, let people with more access to healthy foods. I mean, there is, I think, a lot to be done, at least in my country, so people can really try to focus on the life's essential 8. But I think it starts with the individual, of course, right? I mean, they need to be aware that this is where health starts, right? If we keep all these measures and try not to go to stage 1 and so on. But even if you go to stage 1, there is also a lot to be done and to reverse. So I think that's what is important, and avoid inertia in all stages. We need to try to come back to an earlier stage to keep health. I think that's it.
Viviane, thank you so much. I think we are short of time. We
Yes.
have to finish the section now. Thank you. Thank you, the audience of this video series, and until the next time. Bye
Thank you
bye.
very much, Alberto. It was very nice being with you in this session. Thank you very much.